I'm really going to give an overview, and hopefully there's enough time at the end to answer questions that you might have. So I'll make some very general comments to start with, then I'll talk about SENs and SIGAs fairly briefly, and then I'll talk about tubers and their relationship to epilepsy, and as that's the area where there's the most impact from a neurological point of view in people with tuberous sclerosis. I won't touch on neurodevelopmental aspects because Beck's covered those this morning, and then we'll look at some treatments for SIGAs and for seizures. As I said, hopefully there'll be time for questions at the end. So as you're aware, the neurological manifestations of tuberous sclerosis, like manifestations in other organ systems, are due to overgrowths and abnormal differentiation of tissue. In this case, it's the grey matter and the white matter, the nerve cells in the brain and the nerve fibres. These become often overgrown and malformed, and this is all due to a defect in one of two genes that regulate the pathway. And this is a very important cell signalling pathway. It's very fundamental to all cells as to how they grow and differentiate. It's a well-known pathway to cancer specialists. Lots of cancers are due to derangements in parts of this. Now, the TSC gene sort of put the brakes on the mTOR pathway and just regulate it. And when there are mutations in that gene, the brake comes off and the mTOR pathway is in fact accelerated. And this gives rise to the overstimulation of tissue growth and is key to one of the therapies, the mTOR inhibitors. In terms of what it does in the brain, well, we see a lot of this on imaging, and you can see it under the microscope. We see these abnormalities called tubers. We see subependymal nodules. We see abnormalities in the white matter, and some children can develop these tumours called SIGAs. And these all represent abnormalities of brain tissue overgrowth. Now, the involvement in the brain is variable. There are rare children who don't have any subependymal nodules and tubers, and we heard from Brett this morning about their son Ollie, who surprisingly doesn't have any, but still has many of the neurological manifestations. But by far the majority of people with tuberous sclerosis have some of these nodules or tubers of abnormalities in the white matter, which may or may not have some neurological manifestations. And then there's a whole spectrum of involvement that goes right up to some children who almost their whole brain seems to be involved with tubers and abnormalities of white matter. Now, these particular lesions are mostly static, and you see them, and if you do repeated scans, they're just growing in the brain like the brain's growing. They're not neoplastic tubers growths, except some of these SIGAs that can grow slowly, which I'll come to in a moment. So on the clinical side, so on the sort of manifestations, just like we see a wide range of involvement of the brain tissue, we see a wide range of manifestations of that. And to some degree, there's a correlation between how much the brain's involved, say looking at a scan, with how the child or adult is affected. But that correlation is actually not that strong. So we do see some children who are quite severely affected with seizures and intellectual impairments who have very few tubers. The manifestations can range from people who have some tubers and nodules and these little radial bands on their scans, yet have no seizures, no cognitive impairments at all, maybe just have some skin manifestations, but they've maybe had a child that's been more severely affected. There are children who just have the SIGA problem, so they attend the neurosurgery clinic and they're having their SIGAs monitored and maybe resected, but really don't have a problem with seizures. And then we see a range of seizure manifestations that I'll come to. But some of those are people who develop seizures later in childhood or in their teenage years, and if that's the case, they usually escape a lot of the cognitive and behavioural problems. They're usually otherwise neurologically normal. But the majority develop seizures earlier in childhood, and that spectrum goes right down to children who can have quite severe seizure disorders from very early in infancy, usually compounded by cognitive and behavioural impairments. Now, as I think Claire touched on, the actual manifestations, the severity of those really has changed over the years. So I've been working in neurology for 30 years, and I remember when I first started, people with tuberous sclerosis, the patients I saw, the children I saw, wore helmets, were covered in adenoma sebaceum, and just had horrible Lennox-Gastaut syndrome with drop attacks. And we just don't see those children now. They're much more mildly affected, and it's due to the improved approaches we take and some of the new therapies, the medications, and perhaps surgery. So, as I said, I'm going to talk a little bit about SENs and seizures, and then I'll talk about tubers and seizures. So, the subependymal nodules, the SENs, these are these little lumps. You can see them on the red arrows here. Just these little dots. Some of them are small, some of them are large, and they're like any manifestation of tuberous sclerosis, a little lump of otherwise normal tissue, but in a place where it shouldn't be, and we call that a hamartoma. These are often calcified, and you can see them on a CT scan, and sometimes they'll show up even on a fetal ultrasound. And these things are static, and they don't really cause any problems, except for the ones that are close to where the fluid here in the ventricles, which is white, this is the sort of S-bend where it drains out of. And if these ones here grow, they can block off the fluid drainage. And there's some predilection for the nodules in that location to grow slowly. And these are the ones, when they do grow and they reach a size about 10 millimetres, we stop calling them nodules and start calling them seizures. So a seizure is a subependymal giant cell astrocytoma. It's the same pathology, looking like it under the microscope as an SEN, but it just has some growth potential. We don't know why in that location the nodules grow and why it grows in some children but not others. But usually if they start growing, they'll continue to grow, and this is the reason for doing regular monitoring. If you've got a growing seizure, we're doing scans every 6 to 12 months. If things are pretty static, you're getting a scan every couple of years. The treatments for them now, we have these mTOR inhibitors, and the mTOR inhibitors can shrink seizures. And they shrink them, and they usually keep them shrunken. If you stop taking it, they start growing again. They're very effective medications. If they don't work, or they're not tolerated, or it's still a big seizure, then they need to be resected. And seizure surgery is fairly straightforward. It's you know what needs to be done. It's not like epilepsy surgery. So this is an MRI scan. The top one is sort of face on, and the bottom one's a horizontal slice, but it shows a seizure. And this, so the previous imaging was like this, and what I was showing you were little tiny nodules like that, but this one has grown to this large size here, filling the ventricle, not quite yet blocking off the drainage, but it's also eroding into the neighbouring structures there. And it's really very large. I can't read the figures here, but it's 30, 40 millimetres. And this is the seizure on sirolimus, all right, or everolimus. So here it is pre-treatment, and now it's shrunken right down. You can see it on the vertical and the horizontal slices. But here, here it is grown again when the everolimus was ceased for surgery. So in 1 month from there to there, this child's seizure has grown back even bigger than it was before. And so now we know when we stop the everolimus or sirolimus for surgery, we do it just a week or two beforehand. I think in this child's case, the surgery was delayed. From a surgery point of view, this is what that lesion looked like before surgery, and this is an MRI scan in surgery, so it's an intraoperative MRI. This just is just showing the path, the corridor down to it, and then after surgery, the seizure's all gone. And often with these seizures, it's just a part of it that's growing, and there's another part of it's maybe been there the whole time, and it's sort of hard and calcified and doesn't grow. The important thing is to really get out that growing part, and once that comes out, the children generally don't need to go back onto their mTOR inhibitors. But these days, most people are being treated with mTOR inhibitors, and we're doing less surgery for seizures. Tubers. Okay, so the tubers, these are, again, collections of brain tissue, abnormal brain tissue. Here they're out in the cortex, so they're on the surface of the brain in the grey matter where all the neurons are. And it's these tubers and some of the associated abnormalities in the nerve fibres and the white matter that together give rise to the major problems we see in tuberous sclerosis, which are seizures, language and learning impairments, and behavioural impairments, including autism spectrum disorders. Tubers are present at birth, so like all these cerebral lesions, they're actually present at birth. You may not see them so clearly with early scans because the brain development is immature, and there's a process that goes on during the first 2 to 3 years of life called myelination. And as myelination occurs, we start to see the tubers and the abnormal white matter better. But it's not that the tubers are getting any bigger or more are growing. They've always been there. We're just seeing them better as the children get older. They vary very much in size and appearance within a child, but also between different children. So here's a child that was presented at our epilepsy conference recently who really just has one big tuber. This is over on the right side, one big tuber, and just a couple of little ones like this. She really doesn't have a very large number of tubers. All her other tubers, just these little white little areas you can see here out on the surface of the brain. But this one here is much bigger, and it's also got this little indentation in it and this sort of dark appearance here. And this is what we associate with seizures. So they vary in size, vary in appearance, and different parts of the brain affected differently. And then here's a child who's got many more tubers, and these are over both sides of the brain, and many of them are in the same part of the brain on the different sides. And that's when your brain starts to not work so well. Your brain can actually accommodate problems in lots of areas because the other side can pick up those functions. But when you start to get fairly symmetrically distributed tubers in both frontal lobes and both temporal lobes in similar locations, well, those parts of the brain that would normally be there working are not going to be working properly. Now, the thing with tubers is that some of these tubers cause seizures. When you look at tubers under the microscope, they've got very abnormal brain cells, they're very large and odd looking and have abnormal connections, and some of those give rise to seizures. And we don't know why some tubers do and some don't, and why the different types of epilepsy occur in different children. Now, just briefly going over epilepsy, as you're aware, it's one of the most common manifestations of tuberous sclerosis. Most studies show 80 to 90% of people with tuberous sclerosis have seizures at some point. The peak age of onset of seizures is in infancy. So if you get through the first year of life without seizures, you've gone over a really big hurdle. The seizures that we see are focal seizures, so they start with these tubers in one area, but they can be multiple focal. But multifocal things can sort of get organised and start working as a network, and this is how we can see generalised seizures like tonic seizures and spasms and things. Like, we call them generalised seizures. They have a focal basis, a sort of a multifocal basis, but manifest with this nasty seizure type we see in children called infantile spasms, and in older children called tonic seizures. And seizures in tuberous sclerosis are notoriously difficult to control with medication. There are many people where seizures are controlled, but on the whole, they are difficult to control. Now, the important thing here is that the cognitive and behavioural impairments in tuberous sclerosis, such as intellectual disability and autism, they're highly correlated with seizures. All right? It's extremely rare to see, almost unreported, someone who has an intellectual disability with tuberous sclerosis who's never had seizures. And the correlation is really greatest, that association with spasms, infantile spasms, and other seizures that begin in babies, and particularly if they're not controlled on medication. And there's good information coming out now that early detection and effective treatment of particularly spasms improves developmental outcomes. So how does it do this? Well, this is an EEG recording of a child who presented with spasms. I remember this child very well because the mother drove all the way from the country into the emergency department on a Saturday or a Sunday. I was on call. I saw the child in the emergency department, and the mum said, I think my child has infantile spasms, and I think my child's got tuberous sclerosis. This was about 10 years ago. And I'm, as was pointed out, I'm a straight shooter. And I said, I think you're right. And your child has got that, because she'd been on the internet and seen videos of spasms and pursued the links and found out about tuberous sclerosis. Now, this is all epileptic activity. This is not a normal EEG. This is all epileptic activity going all over. And this child had developed spasms and had lost his visual attention and had lost his smile. He went on to vigabatrin and it wasn't working. So a week in and his EEG is still abnormal, the spasms are still there, and we had to add steroids to the vigabatrin. And steroids are what we commonly use in non-TS settings. And it was only at that point that we were able to calm down all that epileptic activity, and he became visually attentive. And then with a few months down the line, we start to see much more normal. This is a normal EEG now on the right side with normal rhythms, and the child's visual attention improved. The story didn't continue so well after that, though, unfortunately. So, as I mentioned, the seizures begin most commonly in the first years of life, particularly the first year of life. And most studies show that the majority of people with TS developing epilepsy it'll commence before age 3 years. And that age 3 years does seem, the way I think about tuberous sclerosis, does seem to sort of separate the pack a bit. The children who develop seizures early, in those early years, they tend to be not just a single focus, but multiple foci of seizures, and they'll often have spasms, and we'll have a very difficult time trying to localise where seizures are coming from when we're trying to work out from a surgery point of view. And those early seizures have detrimental impacts on their development, and so this is the group where we're most concerned about the development of intellectual and behavioural problems. Whereas children who develop seizures later on, say in their primary school years, well after important aspects of development have occurred, they're usually just a single type of focal seizure with just maybe one arm jerking or the staring or something like that. And there's a single focus on their EEG, a big standout tuber that's causing the problem. They rarely will develop spasms because that's an immature brain phenomenon, and they'll usually escape all the cognitive and behavioural problems. And as I said, the early sort of diagnosis and effective treatment of seizures, particularly early seizures, improves outcomes. So what I was going to talk about now was some of these treatments, and as I said, I'm not going to delve too deeply into them all, but hopefully we've got some time for questions. Starting first with anti-epileptic medications. So I'm a paediatric neurologist, epileptologist. I use all these drugs to treat, not all of them, I use many of these drugs to treat children with different types of seizures. But all these drugs, we call them anti-epilepsy drugs, but they're really just anti-seizure drugs. They just lessen the chance of having seizures. They try and prevent seizures by sort of increasing inhibition in the brain, and as a result, as you're aware, can have side effects due to that. None of these drugs are specific for any type of epilepsy, except vigabatrin. There's something special about vigabatrin, Sabril, in tuberous sclerosis. And this is a medicine that we don't use very much anymore now, except in tuberous sclerosis. There was a while where we were concerned it was going to go off the market. The reason is that vigabatrin seems to be more effective than other anti-epileptic medications for the seizures that we see in children and adults with tuberous sclerosis, particularly the spasms, but also the focal seizures in older children. And that's led to it being first-line treatment for spasms. So when a baby presents with infantile spasms and they have birthmarks and we diagnose tuberous sclerosis, they're going on to vigabatrin. I'm not actually convinced it is actually the best treatment, because other children, if you don't have tuberous sclerosis, get steroids. And steroids have been shown in non-TS settings to be better than vigabatrin. But what we do is we quickly follow up, and if the spasms are not under control and the EEG hasn't normalised, we add steroids. Now, what's happening currently, and this is an important development, and you should keep your eye out for this, is the use of vigabatrin to actually prevent spasms. And there's a practice now and a study going on in the UK, which I think has finished recruiting, and they'll be looking at the results in the years ahead, where we do EEG recordings in in babies who've got a diagnosis of tuberous sclerosis that's been made early enough. So if it was made prenatally based on cardiac rhabdos or seizures, or the baby has arrhythmias in the newborn nursery and is found to have the rhabdos, if we make that diagnosis early, we start doing EEG recordings at monthly frequency. And if the EEG shows epileptic activity, we are concerned that that's the prelude to developing the nasty EEG activity that goes with spasms and impacts on development. And I'm sold on this as an approach. And but it is waiting for the results of this trial, this EpiStop trial, to come out. But if the EEG is abnormal, we put the children on vigabatrin, their EEGs normalise or go back to be focal. The children do not develop spasms in that first year of life. All right. Many of them do develop focal seizures, or when they come off the Sabril, focal seizures and EEG abnormalities will come back and we'll deal with it then, but they escape the spasms in the first year of life and the bad EEG, like I showed you at the beginning, which has the adverse developmental effects. Now, the problem with vigabatrin, though, is that it's not without its own side effects, and what nearly took it off the market was that it is associated with peripheral vision problems. So you can get pruning of your peripheral vision and end up with like tunnel vision if you've been on vigabatrin. And that's something that was observed in many adults that took vigabatrin. It doesn't seem to be a big problem in children. There may be something different about the developing retina. There's some sense that it might have something to do with light, and babies spend much more time inside than adults. So the vigabatrin seems to lead to light-induced damage of your retina. But when we do put babies on vigabatrin for tuberous sclerosis in this setting, it's a risk-benefit assessment, and can't drive because of tunnel vision versus severe learning developmental problems. I mean, it's in favour of using vigabatrin. And it does seem, though, that the incidence of problems is much less in children, in those children who can have their peripheral vision tested. We do get the ophthalmologists involved to do some special testing to keep an eye on that. There are some other issues with vigabatrin that do seem to be reversible. The next line of treatment, as you've heard about, and I'm sure you've heard from the previous speakers about this, are the mTOR inhibitors and their role. Now, these are drugs that act on mTOR downstream here from where the TS mutation is. And if you recall, I said that the mTOR activity is increased in people with tuberous sclerosis, and what rapamycin and its derivatives do is reduce that mTOR activity, or it's trying to do, back towards more normal levels. And it's been shown in trials to shrink tumours such as seizures and renal and hepatic tumours. Most recently, it was shown that these drugs, everolimus, in a clinical trial can reduce seizures in children and adults with tuberous sclerosis. And I think what we see, and this is still largely anecdotal and awaits more trial evidence, but it does seem to improve cognition and behaviour, and you see that commonly in children who take it for these other indications. And I have plenty of my patients are taking this drug, and that is their primary indication. Now, these drugs can be very effective at very low doses. In the clinical trials, they push the doses up very high to get the efficacy, but you saw a lot more side effects. But it's often very effective in sub-therapeutic doses, so where the level is lower than what's normally used. And with that, often avoidance of side effects. And the kids I have just don't have mouth ulcers. One I can recall had some acne, one I can recall had some diarrhoea, but they're really very, very mild problems. They're very, very well tolerated drugs used at the low doses that are often quite effective. There is a need for monitoring, regular monitoring, so you need to have sort of blood tests every 3 to 4 months, and the blood lipids often go up a bit and the blood pressure might be slightly elevated. These are not issues childhood, but they do pose this question about are we going to see a cohort of individuals with tuberous sclerosis 20 years down the line where there may well be some side effects from it. That might be the case, but I think those children would really have reaped the benefits of the medication. Now, in terms of the availability of this, there's two drugs that are available. One's sirolimus and one's everolimus. Sirolimus is the original preparation. Everolimus is a derivative of it. These drugs are widely available and used in cancer therapy and with other agents. They're both on the PBS. There is a TS indication for everolimus. So if you have a SIGA, you can get everolimus on the PBS. I'm sure they're lodging to get seizures as an indication as well. But you can get sirolimus, and it used to be restricted. Now it's unrestricted. So your doctors can write prescriptions for sirolimus without all the hassle of dealing with PBS authority. But as I said, treatment often, once you're on it and you see the benefits, treatments are probably going to be lifelong. From a surgery point of view, we've talked about surgery for SIGAs and how we're doing much less surgery in that setting, but where needed surgery is done. The main place of surgery is for epilepsy, and here epilepsy surgery is used for children and adults who have seizures that are resistant to medications, that are problematic, for medical reasons or quality of life reasons, or in young children we're concerned about or seeing the detrimental effects on their development. The difficulty with epilepsy surgery and tuberous sclerosis, and why lots of places don't do it, is that you're trying to work out which of many tubers is giving rise to seizures. And the treatment is to take out the tuber that's causing seizures. Tubers are non-functional, they have no other function. The problem is that they cause seizures and affect the normal brain around. So taking out a tuber or several tubers doesn't cause any problems. The hope is that it is going to fix those seizures. The studies around the world suggest 50 to 60% of people who with TS who have surgery will become seizure-free. Now, the studies that are done around the world, that's picking the easy cases. These are these children, adults, later onset, a single focus, and yeah, those are easy. The real difficult kids are like Christian, whom we heard about, and where seizures started early and they're multifocal with spasms. And these children sometimes need multiple operations, and the end of that might be that you knock off 2 of 3 types of seizures and the child's left with a mild seizure. Occasionally some of these children are seizure-free, but sometimes the seizures are just unrelenting. A big problem we have is that seizures spread from tuber to tuber, and this is an EEG recording with a child who's got electrodes inside the head. We don't do this as much now, but where the seizure starts in this tuber here, this is the seizure taking off, and then it spreads to this tuber and then spreads to this one in the other hemisphere. And this plagues us trying to work out from all the recordings and things where seizures are coming from and what surgery is going to involve. In terms of other treatments, there are several, and again we're getting back now to just general treatments for epilepsy. So mTOR inhibitors and tuberectomies and vigabatrin, they're things that are very specific to tuberous sclerosis, but the whole range of anti-epileptic medications can also be used. A ketogenic diet is commonly used for children with uncontrolled epilepsy. It's a very medical diet. There's nothing healthy about it. It's sort of largely mimicking starvation, but it's known to be effective for seizures and maybe even has some extra benefit in TS. There are some studies that suggest it has some effect on the mTOR pathway over and above its effect on seizures. Vagus nerve stimulation and perhaps deep brain stimulation. These are forms of neuromodulation. We use these devices in people that have seizures that are not controlled by drugs and diet and surgery and so forth. It's been around for quite a while. There have been difficulties with funding, and fortunately on the 1st of November, finally VNS is going to be on the MBS. It's finally got up, and so it'll be available much more widely and to private patients and so forth. It's probably most effective for people who have the more severe seizure types like tonic seizures, like in a Lennox-Gastaut setting. And look, it's not a cure. You rarely get people who are seizure-free, but it often just takes away the severe aspects of seizures, the nasty drop attacks, the prolonged convulsions, the trips to hospital. Just takes away the edge of the epilepsy. Immunotherapies, we use these in other types of epilepsy, less commonly in tuberous sclerosis, but steroids, gamma globulin are used. And then you can't do an epilepsy talk these days without talking about cannabis, so let's get this out of the way. So medical cannabis, so I'm going to just talk briefly, and hopefully the question time doesn't totally involve cannabis. But the cannabinoids are a group of compounds. They're drugs, and they're lots of drugs. So when you look at cannabis extracts, there's so many pharmacoactive compounds there, some of which are neuroactive and psychoactive. But there is evidence for efficacy in seizures. There's a lot of scientific work that's been done looking at cannabinoids and their effect on animal models and which receptors and things they act on. There were plenty of small series, this little descriptions of groups of patients with different conditions, and as you're aware, sort of a large uptake outside of normal medical practice. Just this year, finally, a proper clinical trial was done, or two trials actually, which did show efficacy of cannabinoids. And this was a compound made by a UK group, probably one of the more reputable groups, GW Pharmaceuticals, very high level of manufacturing standards and regulatory standards and so forth, and put their compound through the standard device for seeing if a compound or a treatment is effective, and that's a randomised clinical trial done in a blinded fashion where some people are getting the medication and some are getting placebo. And this was trialled in Dravet syndrome and in Lennox-Gastaut syndrome, and like with most of the new anticonvulsants that eventually come onto the market, had a significant responder rate, which is the proportion of people that had a 50% or greater reduction in their seizures compared to the placebo group. But like lots of medications that act on your brain for seizures, they were not without side effects. And certainly side effects are a big issue with these compounds. There's a degree of sedation, vomiting and diarrhoea issues, and some of these compounds, there are abnormalities of liver function that need monitoring. There was a study reported, just a description of a handful of patients from the US, I think about 20 children and adults with tuberous sclerosis who were given a CBD compound. I'm not sure if it was the Epidiolex product or not. They reported in this non-blinded fashion that 50% of the patients that received it had a 50% reduction. But we don't put a lot of weight on these sort of open label studies. We need these randomised trials. There is a study in tuberous sclerosis that's underway currently, and again the Epidiolex manufacturers are sponsoring that. It is available in Australia. There's 3 hospitals in Melbourne, one in Brisbane and one in Sydney that are running this trial. And again, it's the type of trial that's very informative. It's a randomised trial, blinded, where there's 2 dosing levels for the compound and a placebo group. So we'll await the results of that trial. But it's likely that it will show efficacy, and it'll be added to the list of compounds that might be worth trying. The big cloud over these drugs, though, is what are their effects on say the developing brain? Would you give these compounds to an infant? And we know that the cannabis in its other forms can have detrimental effects on development. So just to finish up on research, and as mentioned, this is an area that I've been drawn into and become very interested in, and on the epilepsy side with my colleagues here in the hospital and in the Murdoch, over at the Florey and at the Austin, we've been doing quite a bit of research. We've published on where seizures come from. There was a big debate in the literature about where they come from, and we've had a couple of publications in high-level journals that say it's the tubers, and stop taking out normal brain in people with tuberous sclerosis, just find the tuber. We've done some work where we've sent resected tissues off to have an MRI scan, but this is a 16T, not a 1.5T, 16 Tesla scan, and it was scanned over a weekend, not just 30 minutes. So an enormous amount of data, and we're looking at the microstructure of tubers and what's going on in there, because we have this information that suggests there's something about the centre of these tubers where there's a pit where the seizures are coming from. We've done some work where we've resected tubers and they've gone into a special liquid medium and raced off down to the Florey, and they've been able to do experiments looking at the excitability of the brain cells in there. And we're currently doing some work that is looking at the genetics of tubers, and this question that comes up is why is there a lump or a tumour or a tuber or whatever in this part of the body in that location, and why is this one still and that one's growing, and so forth. And it's this phenomenon of a second hit, in that in the other copy of the gene, one copy of the TS gene has a mutation in it, but the other copy or another related gene in the pathway gets a mutation in it, and there's probably a lot of variability in where that is, and we're going to be looking at that in different parts of tubers. Much of this research has been sponsored. We've been lucky to get an NHMRC grant for this current genetic work. As Beck mentioned, Con and Joe have done an enormous amount of fundraising, and we've been the beneficiaries of that, and we're very grateful for the sponsorship that they've provided. So I'll finish up just summarising that, as you'll just keep hearing about, there's a wide spectrum of manifestations, both sort of pathologically in the brain in terms of what we see on scans, but also clinically and how it manifests in people with epilepsy in terms of the nature and severity of their seizure and cognitive and behavioural issues. An important point is this monitoring of EEGs and being ready to jump in and use vigabatrin to prevent spasms, and this is a real watch this space, and this is going to have a major impact on developmental outcomes for people, and we're going to see, unfortunately, probably two groups of kids with TS, those that are diagnosed early and get this treatment, and those that are picked up later. And it will sort of raise the issue of then, I think, is this something we should be screening for? Should there be better screening for tuberous sclerosis? Seizures need to be detected and treated promptly, and it really should involve a neurologist. A paediatric neurologist should be involved in management of seizures in TS. It's a very difficult area. Any developmental issues as they come up, but not even just waiting for them to come up. There should be screening for problems with behaviour and learning, and organising effective interventions. I've spoken about regular surveillance, particularly with MRI for seizures, and then consideration of surgery where it's needed for seizures, but also for surgery for epilepsy, and that there are children where the drugs clearly aren't working, and we need to do something quickly, and should be be seen at a centre where you can be evaluated for surgery. And then the mTOR inhibitors, these we're using them more and more. They're currently indicated for growing tumours like seizures and AMLs. They'll soon be have an indication for seizures, and probably also for other aspects of tuberous sclerosis. And maybe this will be the precision therapy that exists for tuberous sclerosis, and maybe one day everybody who has it will go onto it in some way, as long as we have a better way to monitor therapy. So I'll finish up there. Thank you for your attention, and thank you again for the award. I'm very honoured. Thank you.
We're running just pretty much on time, but I'm going to make time for, let's say, 2 questions. If anyone has something they'd like to ask Simon. Oh, Les.
Oh, hi. Thank you very much for your talk. Very interesting. Now, I understand that the tuberous nephromas in younger children, there appear to be gains in that that's actually keeping them under control. with adults, and I'm talking about my son specifically, his brain looks like a patchwork quilt. Now he's on everolimus. It's clearly fixing up all of the external parts. The rash around the face is gone. Is there any research underway, or have you seen evidence that the tumours in adults are being significantly reduced, or is the calcification in them such that they're not going to be removed anytime soon?
So tumours don't grow. They stay, they don't get bigger and they don't go away. So they don't grow like SIGAs and they don't shrink like a growing SIGA or an AML. They just don't change. So there's no indication to take an mTOR inhibitor just for tumours, right? But the tumours cause seizures, and the everolimus, sirolimus is effective in some people for controlling the seizures. So it's the sort of functional, not the structural aspect of it. So there's those two aspects of how these mTOR inhibitors work. They shrink things that are growing, but they also do something at a functional level downstream from this pathway.
Thank you.
Hi. How do you get chosen to use the inhibitors? Like, my son's on the sirolimus for his face through Dr. Orchard, and that's clearing that up. But how, like, he's got SIGAs, so how do you get chosen to...
Well, from a SIGA point of view, it's if your SIGA is growing, and SIGAs tend to grow during childhood and adolescence. They tend to have finished their growth in adulthood. So if you're an adult, you don't typically need to take an mTOR inhibitor for a SIGA. But if you're a child or a teenager with a growing SIGA, you potentially have an indication to go on it. That might be because you're concerned about the SIGA, or it might be you just want to access the everolimus and the growing... Sorry? Okay. Okay, but the thing is, if you meet those criteria, there's you might get other benefits.
So, at what rate of growth would you like? A millimetre each year,
well,
or
the PBS stipulation is based around that it's going to prevent obviate the need for surgery. So that can be read in different ways.
Okay.
But you don't have to take everolimus. We can use sirolimus, and sirolimus works just the same. And there's no restrictions on using sirolimus. So it's doctors using these medications off-label, which we can do, but it's using a drug not for the primary purpose that it's designed for, currently indicated for, reimbursed for. These are all different levels.
So would it be getting absorbed through the skin when he's on the one for his face?
No.
The trials into the skin cream have demonstrated pretty conclusively that it's not getting absorbed, so really different. And the reverse is that if you're taking mTOR inhibitors internally, most people report that there's some benefit to the skin, but a lot of people in TSC, seeing TSC specialist doctors will be doing both now as well. So the internal medicine isn't necessarily, well, we're seeing that it's not as effective at treating facial angiofibromas as the cream is. It seems to need to get there.
The thing is with mTOR is the mTOR activity is actually different in the different cells, in the different lesions, in different parts of the body. And so whilst we might think of it as precision therapy because the drug goes right to the problem, it still is sort of shotgun therapy because you don't really know what it's doing to the actual mTOR activity in the particular target tissues. All we can really do is monitor blood levels of the drug and look for evidence of toxicity and of benefit. So it's very rough. There's a lot more needs to be done to be doing mTOR therapy better in TS.
Helen, did you want that question? Yeah.
My question was similar to the first question in that if all the tumours are present at birth, does anyone sort of develop anything in adulthood, or is it really, if it's not there when you become an adult, you're not going to get any brain lesions?
Not in the brain, yes. So the only thing that will change in the brain is a SIGA. But as an adult, if your scans are clear, they're clear.
Okay.
And there
So
are-
if you have a clear scan as an adult, you
Yeah.
don't need to scan them again?
That's right, yep.
Except for SENS and Seegers, right?
What?
Except for SENS and Seegers, you might still want to be doing monitoring.
If you've got a normal scan,
Yep, with nothing at all.
no,
Yep.
there's no need to. And even if you've got some SENs and some little bands or tubers there as an adult, nothing's going to grow.
There's been a couple of cases where we're unsure of what the baseline scan said, but suddenly a Seeger pops up in someone in their 30s. So it always makes me nervous when the doctors say, you'll be right once you get to 25. And then, you're like, oh, but except for if you're in that tiny percentage. But it's challenging, isn't it?
Yeah, but there probably would have been someone who's had growth.
Yeah, possibly.
But, yeah.
Yeah. Nothing's ever easy. And I think for Linda's question, sometimes it's a matter of finding the right neurologist who's willing to be a little bit more, I suppose, aggressive or, push the envelope and say, we can try something new for epilepsy. And so I just wanted to say thank you, Simon, for spending your time with us again on the weekend. And you've got one award, but I'm going to add to that with a bottle of wine. Thank you so much.
Thank you very much.